Okay, thank you. All right, well, thank you everyone for being here today. Like I said, my name is Hugh Quinn. I'm a clinical pharmacist here at WVU Endocrinology. Thank you to everyone for the invitation for here to speak. I'm still pretty new to this area, just moved down in August myself, but I've enjoyed it a lot so far, so I'm excited to be here, and I'm really looking forward to helping out the patients in the area in any way I can. One of the biggest issues that we face in healthcare treatment, unfortunately, is access to medications, and commonly the biggest barrier to access does come down to cost. So I was asked to come here today and speak to you guys about medication coverage, and hopefully I can point you in the directions of some resources and give you some tips and some guidance from my personal experience and ways to make it easier and hopefully improve some of your prior authorization determinations and help get these patients on the medications that they need. Let's just start off. I have no financial disclosures, no affiliations. Any mention of brand names in this presentation is just for identification purposes only. The objectives of this presentation will be to review the resources that are available to determine coverage. We won't go too in depth into what plans cover what medications, just because there's so many out there and they change so frequently. I didn't think that would be a good use of the time, but we will discuss some general classes of medications and some specific medications that are commonly prescribed for patients with diabetes. And I'll provide some guidance on how to improve the favorability of your outcomes. And again, like I mentioned, just give some tips and ways that I found to improve the probability that you'll get a favorable outcome when submitting these prior authorizations. So I'm sure you guys are familiar with the fact that diabetes is a very costly disease state in this country. It is estimated in 2017 that 1 out of every $7 spent on healthcare was spent to treat diabetes or its complications. So it's a big part of our healthcare system. A lot of money goes into it. Just in glucose lowering medications alone, in 2017, over $57 billion was spent. So that's just the glucose lowering medications itself, not including medications to treat its other complications, which when you look at that leads to a 2.3 times greater cost in treating patients that have diabetes than those that don't. And again, these estimates are from 2017. So as you know, this trend has been going up, and this problem is only going to get worse within this country. Here's estimates of the trend of the prevalence of diabetes, and you can see at the time of this data in 2016, it was trending up pretty rapidly, and if this is going to continue, the cost of treating diabetes and the cost of medications is only going to go up. In terms of the complications treated with diabetes, it is estimated that it costs $47,000 per patient over 30 years. And over 30 years sounds like a long time, but we're talking about tens of millions of patients here. So this value can add up pretty quickly, and it's become a pretty staggering financial burden. Most commonly, the biggest amount of money spent does go to macrovascular complications, which accounts for 85% of the cost, but then there's other ones including nephropathy and neuropathy and retinopathy, which make up the most. So as mentioned, it's not just treating the diabetes, the glycemia itself, it's treating the complications that are associated with it and the comorbidities that really add up to the astronomical costs of treating patients with diabetes. This table just breaks down where all those costs go to in treating these patients. Really all I wanted to highlight here, again, is that even if you take out insulin, the cost of medications in these patients is staggering, and then the other prescription medications that they are on here add up a lot. So this is kind of what I think leads to a lot of plans sort of cracking down and trying to limit the use of medications to using them appropriately, but also judiciously and in fiscally responsible ways. Getting into a little bit more about commercial coverage and how to determine coverage for patients. This is an app that I'm fairly new with. I haven't used it a lot, but I've been told it can be pretty helpful. It's called Coverage Search. It is available to download both on Google Play and Apple Store. And you can see a little screenshot of it from here on the right. You can search by medication and an area and which type of insurance, and it'll list the plans for that medication and whether it's a preferred medication, if it requires a prior authorization or a step therapy. So I'm told it's generally pretty accurate, but sometimes it's not up to date, which with the number of plans and the number of medications that it services is kind of understandable. Again, that's the coverage search app that's on both Google and Apple Store, and it is free to use also. A couple other resources. You guys are probably pretty familiar with GoodRx, but one that I wanted to make sure I mentioned was the HealthWell Foundation. I've had a lot of experience using this foundation. They do have assistance programs for over 80 different disease states. It's pretty easy to utilize. The website's there. You can just Google HealthWell Foundation and it'll come up. They've given over $650 million in 2020 alone, and to over 600,000 patients since 2014. So it's a large program. They have a lot of disease states. The individual funds go by disease state, and when the funds run out, the fund closes. So it's kind of a first come, first served basis. So this time of year, a lot of the funds are closed, but they keep an updated list of what's open and what's available. Most of them are income-based for eligibility, and they all have their different specific requirements. When you click on them, it's pretty easy to determine if the patient qualifies or not. They don't just cover prescription costs either. They also help cover insurance premiums and travel costs for patients as well. So it's a really good foundation that has access to a lot of resources. I use as an example here of hypercholesterolemia. So this particular fund is for Medicare patients only, but most of them are not. And you can see here, it is closed currently because they have used all of the funds available, but it'll tell you what the maximum award level is per year per patient. So $2,500 per patient. They give you what the household income requirements are there. So 500% of the poverty level. And then you can see it's not medication specific, it's disease state specific. So you can use this to get coverage for a lot of different medications. And again, also help cover insurance premiums and travel costs and a bunch of different things. So they're a really great foundation that they're pretty easy to work with. Diabetes itself is not a fund that is available, but a lot of the comorbidities are, like hypercholesterolemia, heart failure is one. They cover gout. They do cover diabetic foot ulcers actually too. So of those 80 disease states, there's a lot that are available that we can help reduce the costs of these medications for our patients. Switching from commercial over to Medicaid a little bit, these are the links for the preferred drug lists for each of the states that are in this area. Again, these things are things that change rapidly, unfortunately. So the links are available here. Some of them are updated October 1st, some of them July 1st, but these are the most up-to-date links for the preferred drug lists. And this is where a lot of the information that I'm going to talk about with these specific drug classes coming up. So with SGLT2s specifically, you can see it is a preferred medication for most plans, and that's because we now have a lot of data for its benefit in a lot of different disease states and a lot of risk factors. So you can see here in West Virginia, it's a preferred medication, all three of them across the board. There is a fourth SGLT2 inhibitor, Trulicity, but that's not covered by any of the plans actually, and I don't think I've ever seen it actually prescribed in the US, so I won't be mentioning that going forward. But as these indications expand and the use of these medications become more common, I think coverage will begin to improve. Even though it's a preferred medication, it may be tier 2 or tier 3 for commercial insurance coverage patients. So it could be a little bit more expensive for those patients. It's not that it's not covered, it's just that the copay might be a little higher than what they're used to. So for those patients, there are commercial savings programs available. And I provided the links here to the individual programs here for you guys. They're fairly simple. Again, they are usually income-based. So patients can fill out the applications themselves, or sometimes I'll do it over the phone with them. And then turnaround time is usually pretty quick, but they just get an insurance card that they bring to their pharmacy and they put the information in. And usually it covers the majority of the cost of the medication. You can see there are limits for those cards. In terms of GLP-1s, coverage is a little bit more limited. It appears that Trulicity generally is the preferred medication. We'll talk a little bit about why that might be going forward. But as more data comes out with semaglutide for both Ozempic and Rybelsus, that may change going forward. So right now, it's currently not a preferred medication for any of the Medicaid patients in the area, but Trulicity is. So if you're not sure which one's covered, it's probably going to be Trulicity that you have the most chance of getting covered. And again, for those on commercial insurance with these medications, there are savings card available for Trulicity, Ozempic, and Rybelsus. Victoza itself doesn't have a savings card program, but they do have Novo Care, which is available for almost all of the Novo Nordisk products. So that could be used for Ozempic or Rybelsus also as well. And again, the links are there for these programs that patients can submit the forms themselves for to see if they qualify, and will get a copay card to use at their pharmacy. I wanted to highlight these two medication classes themselves specifically, the SGLT2s and the GLP1s, because of recent updates that have been made in the past few years with a lot of trials that have been going on and the guidelines that have come out with new recommendations for them. So both SGLT2 and GLP1s have been included in guideline recommendations for the American Diabetes Association, as well as the American Association of Clinical Endocrinology, to be used regardless of A1C. So even in patients that are below goal, either whether that be 7 or 6.5, these medications are still indicated or still recommended by both of these groups if they have high risk or established cardiovascular disease, CKD, or heart failure. So even in a patient that has an A1C of 6.2, they're well controlled. If they're at high risk for cardiovascular disease, it is recommended by both these organizations that they be on either an SGLT2 or a GLP1 or even both. And that recommendation is echoed in the FDA labeled indications. You can see here the indications for Trulicity, Ozempic, and Victoza. They're pretty similar, but there are some minor differences. You can see with Trulicity, it's indicated to help glycemic control, but also to reduce the risk of major adverse cardiovascular events in adults with diabetes who have either established cardiovascular disease or multiple cardiovascular risk factors. So Trulicity is unique in that way that it's indicated for primary prevention also. So you have a patient with diabetes, even if they haven't had a prior event, if they have risk factors, it is indicated and recommended to use Trulicity. The other two, Ozempic and liraglutide, or semaglutide and liraglutide, don't have that indication for primary prevention yet. And that's mainly because Trulicity, when they did their Rewind cardiovascular outcome trial, they had 60% of patients that were primary prevention in that trial. So they were able to show that it does reduce the risk in primary prevention as well as secondary prevention. Semaglutide in their trial of the SUSTAIN-6 trial for cardiovascular outcomes, they only had about 30% primary prevention, so they haven't been able to show enough data that it has benefit in primary prevention yet. And liraglutide had only about 20% primary prevention in their trial. So it's not that those medications don't work in primary prevention, they just haven't been able to present enough data to the FDA to be granted that indication as well. Switching over to PCSK9 inhibitors, I want to talk a little bit more about doing the actual prior authorizations and trying to get these medications approved for patients in which it is recommended and indicated for. So you can see here with the FDA approved indications for these medications, both Repatha and Praluent, they're indicated for secondary prevention, but also for primary prevention in patients with primary hyperlipidemia. So that includes heterozygous familial hypercholesterolemia and homozygous. And again, that goes in line with the ADA recommendations and the ACE recommendations. So ADA recommends these patients for secondary prevention, but also for those on maximum LDL lowering therapy and an LDL below 70. So the way the ADA has set it up, really, if their LDL is above 70, you consider using ezetimibe, and then if it's still above 70, you can consider using a PCSK9. ACE recommendations are a little bit different. They don't include that Zetia step in there. They just recommend those that are on maximum tolerated statin and not below threshold. So the only issue I really have with the ADA guidelines is you only get about a 12 or 15% reduction with Zetia in LDL. So patients that are far from goal, starting the Zetia medication and waiting a while is kind of just wasting a bit of time. It might be more beneficial just to jump straight to the PCSK9 therapy if you need like a 30 or 40% reduction in LDL, because you're just not going to get that robust of a reduction with ezetimibe. These recommendations are getting pretty aggressive. I have the ACE recommendations for LDL thresholds here. And you can see with our diabetic patients and the very high risk, all it takes to be in this category is diabetes and one risk factor. So hypertension, hyperlipidemia, smoking, obesity. I don't think it's too hard to find a patient with diabetes that has at least one risk factor. So our LDL threshold in most of our patient population is going to be below 70, which is pretty aggressive. And then in patients that have diabetes that have had an event, so this extreme risk category group, the LDL recommended threshold is actually below 55. So these are getting pretty aggressive in patients, and in a lot of patients, we just aren't able to get there with statin therapy. Zetia is great if you're close, but again, that 15% reduction isn't going to do too much for many of our patients that really need a robust LDL reduction. So a lot of patients are candidates for these PCSK9 inhibitors, which we would expect to reduce the LDLs by at least 50%. So the issue with getting it approved in patients for primary prevention is that the FDA only recommends it for secondary with ASCVD history or primary prevention with primary hyperlipidemia. So you have to be able to show that the patient has a heterozygous familial hypercholesterolemia in some patients if you're going to use these medications for primary prevention. And one way that or a few ways that I've been able to help support that with a bunch of plans. Again, each plan negotiates their own requirements for when they will cover these medications, so it's difficult to make generalizations. But here's a few ways that I have had success in these medications approved. Using coronary artery calcification scores. Unfortunately, some of the plans don't cover the test to have this done, so patients have to pay out of pocket to get the test done in order to have the medication covered. And this 300 Agasston units is also kind of an arbitrary set off. Some plans are higher, some are lower with what they require. It's kind of an odd requirement because this coronary artery calcification score doesn't appear anywhere in FDA recommended use or anything like that. So I'm not sure how they were able to negotiate those in their plan requirements. But the other way is by, again, supporting the fact that the patients have heterozygous familial hypercholesterolemia. And what that usually requires is an LDL equal to or above 190. And if you have that, you could qualify for the primary prevention indication if you're able to use the Dutch lipid score and calculate a score of usually at least 6. So this score is mostly based on interviewing the patient to get a family history to determine what their risk factors are. So collecting a good family history is really important in these patients. The other way to use the Dutch lipid score to support the diagnosis of familial hypercholesterolemia is to look for these xanthomatas, so these cholesterol deposits in either the ankle tendons or hand tendons. That's what the score specifically mentions. I have been able to use the score to get it approved if these xanthomatas are in other places like around the eye or on the cheek. So some plans are more specific, that has to be in these areas, in the Achilles tendon or in the hands. Some are more willing to be a little more lenient, and if they have xanthomata in other places, they will approve the use of the medication also. Another thing that we will look for on physical examination of these patients is the arcus cornealis, so this sort of gray-blue circle around the outside of the eye. If they have either one of these things, it counts as 6 points towards their Dutch lipid score. So along with an LDL greater than 190, it suggests that they have definite familial hypercholesterolemia. If you're able to get an LDL above 190 and a family history or something like that, it's also pretty easy to get a score of 6, which is just probable familial hypercholesterolemia. And for most plans, that is enough that they will cover the medication. And that LDL of greater than 190 is untreated. So if you have a patient who's on maximally tolerated statin and their LDL is like 120, you can justify that an untreated LDL would likely be over 200 because that high dose statin is probably reducing the LDL about 50%. So if it's 50% lower at 120, you can estimate that their LDL would be above 190 if not treated. Another medication I want to specifically talk about that I see a lot of issues with access to is icosapent ethyl, or Vasipa. So what makes Vasipa unique is that it's a highly purified form of the ethyl ester of omega-3 EPA. It does not contain DHA, which is what makes it different from over-the-counter omega-3 fish oils and from Victoza or its generics. And the complicated part with this medication is it actually has two FDA indications. One is the old one that's been around for a long time to treat hypertriglyceridemia in severe cases with triglycerides above 500. But the other newer indication that came out just a few years ago is as an adjunct to statins to reduce cardiovascular risk in patients that either have established cardiovascular disease, so in secondary prevention, or in primary prevention in patients with diabetes and two additional risk factors. So again, patients with diabetes and then two of hypertension, hyperlipidemia, smoking, obesity, any two risk factors fall under this indication, as long as their triglyceride levels are over 150. But the issue with this medication is if you submit a prior authorization and you click the indication of hypertriglyceridemia, unless their triglycerides are over 500, it's going to be denied. So most times that's not the appropriate indication to be using. And when you're doing a prior authorization, either on Cover My Meds or with the paper forms, you need to make sure that you indicate the indication is for cardiovascular risk reduction. So in these patients, say they have a triglyceride level of 200, and you say it's being used to treat hypertriglyceridemia, it's going to be denied. But if it's 200 and you're saying it's used for cardiovascular risk reduction in a patient with diabetes, hypertension, and hyperlipidemia, then it's more likely to be approved. The other issue with this medication, to make things even more complicated, is a generic was put on the market 2 years ago. And there were some court battles between the makers of Vasipa and Hikma Pharmaceuticals, the maker of the generic. So it's kind of odd that these decisions were made within the courts, but the generic was not granted the approval for cardiovascular risk reduction. So the generic icosapent ethyl is only approved for treatment of severe hypertriglyceridemia. So it's a little bit of a caveat. It's supposed to be the same thing because it's a generic medication. But if you want to be most specific to the data and the FDA approved indications, only Vasipa is approved for cardiovascular risk reduction. So if you're prescribing this medication and you want Vasipa, you have to indicate that you want brand medically necessary, or it might be filled for the generic, which is not approved and doesn't have the data for the indication that you're using it for. Another thing I want to talk a little about more is step therapy. So a lot of times we hear these indications or recommendations state maximally tolerated statin. This can be no statin. Some patients don't tolerate any statin. So just because a patient's not on a statin doesn't mean they can't qualify for these medications. Usually they will require a trial of at least 2 statins. And some plans actually require claim data to be checked to prove that the patient has tried 2. So just writing a prescription isn't enough to state that the patient tried 2 statins. They actually want insurance claim information that the patient picked up the prescription itself. So I find that to be a lot of barrier if a patient pays cash or they picked up the prescription another way. They might have been taking it, but they don't have that insurance claim. So the insurance company is not going to approve the medication because they don't believe that they tried at least 2 different statins. So making sure the patients pick up the prescriptions and they get that claim data can be really important. And a lot of times they also require it to be high intensity statins. Usually it's at least one, either or rosuvastatin or atorvastatin that's required within step therapy, and it's got to be for at least 6 weeks. And then again, a lot of step therapies include ezetimibe in these plans, but the LDL reduction for that is pretty modest. So if you are able to state that they need a much more robust LDL reduction, sometimes you can get around this step within a plan. Another medication I want to talk about a little more in depth, it's a newer medication that was just approved in 2020, is Benbedoc Acid. So this is a new mechanism, a new class of medications for lipid control. It's an adenosine triphosphate citrate lyase inhibitor. And this actually works upstream in the cholesterol production pathway of the HMG-CoA reduction, which is where statins work. So by using this medication, you're able to hit the pathway in 2 different ways if they're on a statin and get a much more powerful reduction in LDL. What's unique about this Benbedoc acid is it's actually a prodrug that's activated by an enzyme that's most commonly found in the liver. So it doesn't get activated in the muscle tissue, so you're much less likely to have myalgias. So this could be an option for a lot of patients that are statin intolerant or that are on maximally tolerated statin but not below LDL threshold yet. In terms of versus placebo, what kind of response you can expect? It's about a 17 or 18% reduction in LDL when used with statin. or when used in combination with statin and ezetimibe, it's an additional 38% reduction. So a pretty robust LDL reduction in patients. So this may be something that could be considered commonly in patients that are sort of in that between they're on a statin and they might not need a PCSK9, or they're reluctant to use the injection. This could be a good option for a lot of our patients. And it's in 2 different forms on the market now: Nexletol, which is just the Benbedoc acid, and Nexlizet, which is the Benbedoc acid combined with ezetimibe. So it can help ease that worry about increased pill burden by adding more medications. Patients on ezetimibe already, it's not an extra pill. You can just prescribe it with Benbedoc acid, and they're still taking the same number of pills. For Benbedoc acid, its approved indications are, again, heterozygous familial hypercholesterolemia and secondary prevention of ASCVD. So it may have those same barriers with using the proper indications and having to prove that the patient has heterozygous familial hypercholesterolemia. And there is a copay card for it available, where you pay as little as $10 for a 3-month supply. So with submitting those PAs, it is just important to use the proper indication, because if you submit it for ASCVD treatment and the patient doesn't have any documentation of ASCVD in their medical record, it's not going to be approved. But if you're able to support a diagnosis of heterozygous familial hypercholesterolemia, it's much more likely to be approved by the carrier or by the payer. So overall, the coverage plans change frequently, and there's a lot of them out there. So it's pretty difficult to keep up with what the requirements are for each one and which medications are covered by individual plans. But there are a few different resources out there that I think you guys might find helpful. And there's a lot of savings programs and foundations available to help reduce the cost to patients. But when it comes to submitting prior authorizations, I think the biggest issue and the biggest barrier to approval is using the proper indication and making sure that when we're filling out either on Cover My Meds or in the paper forms, that we're selecting the right questions and answering them appropriately to improve our chances. And just padding the requests with as much information as you possibly can to support the indication for the medication, using as much information as you can from the medical record. And then I've also had a lot of success with using appeal letters. It sounds like a lot of work, but once you make a template for one, it's pretty easy to just fill it in with the patient-specific information. And if you use these and you cite guidelines and primary literature, I think the success of the appeals being approved are pretty good. So with that, does anybody have any questions for me?
Thank you so much, Hugh. You did a great job and provided some excellent resources within our slides that I'm sure people are going to utilize. So we appreciate you and your time.
Yep.
I see unmuted, Dr. Paliwal.
Yeah, thank you for the presentation. It was really good. And I missed in between the presentation. I don't know whether, did you talk about Wegovy?
I didn't, because we were supposed to be talking diabetics specifically, but Wegovy, right now, I guess access, there's a bit of supply issue with the market because it was in such high demand at first. It's supposed to be coming back soon. But is there any specific questions you had about it, or?
Any tips to get it approved?
It's only approved for weight loss. So you're going to have to use the weight loss indication only, which isn't hard because the patients just need a BMI of 27 plus obesity related risk factors. So most patients are candidates. So if they have commercial insurance, it should be, well, they may get it covered for commercial insurance. Unfortunately, most state programs don't recognize obesity as a medical condition, so they won't cover medications for obesity. So commercial insurance, there's a chance, and there is copay savings cards. If you're on Medicare or Medicaid, it's going to be difficult.
Thank you.
Yep.
Thank you, Dr. Paliwal. Does anybody else have any comments or questions? Do you have a question, Smina? No? Okay, so your camera will come on, so I just wanted to make sure. All right. Well, if not, I will make that last announcement. I'll include his slides into the recap as well. And our next session is going to be canceled for Thanksgiving week. So we won't see you until after Thanksgiving. So we hope you have a really wonderful Thanksgiving. You can celebrate that holiday with your friends and family. And then our next session will be, I think, December 8th. Oh my gosh, don't write down. And Smita's going to actually be doing evaluation and management of osteoporosis. So thank you guys so much. And I hope you have a wonderful day.
Thanks, everyone. Take care.